And patient number one might be like, hey, you place these anterior restorations for me and they keep breaking. My fillings keep chipping, my crowns are chipping, I'm not happy. Versus the patient who's taken ownership of their bruxism, and they're the ones who come to you, and after they chip something, they're like, hey, I'm so sorry. And they're apologizing to you. They're not blaming you, they're blaming themselves. Why? Because they know. Happy New Year to the Protrusive RT. Welcome back to the show. I covered a lot of stuff regarding splints and occlusal appliances in September. Remember, we call it Splintember, and that was real fun to record, but I felt as though I couldn't do it justice. I did have more to give, and just never got around to making this AMSA Part 2, which I did promise you. So it's finally happening right now. AMSA Part 2. Let's continue from AMSA Part 1 and finish off the Splintember series. These solo episodes, they really do take it out of me. It's actually really challenging to talk in front of the camera. It's so much easier just to have a chat with someone who you want to learn from. But it's great fun to do this. Ultimately, it is something that really challenges me. In fact, recently on the Protrusive Dental Community Facebook group, I asked you all which was your favorite episode of episode series of 2020, and I listed every single one of them, all 38 or how many there were throughout the whole year. And I was humbled that you guys had chosen the Splintember series of all the different episodes. So thank you so much. And I'm hoping that I will do justice with this episode. You guys really encouraged me, so thank you. So we also finished 2020 on quite a high. I won an award. The podcast won an award for the best podcast in occlusion and treatment planning, thanks to Course Karma. And I'm so grateful to whoever that one person was who voted for me initially. And that set off a chain reaction. And so many others ended up voting for me. And like, if it wasn't for you, that one first person, I may not have even discovered Course Karma. It's such a fantastic resource for dentists around the world to find courses, basically. So, you always wanted that sort of one reference where can I find all these courses? We usually end up going on Google or asking on Facebook. But what Course Karma is trying to do, and it's still, it's still got a bit to do to get there, but I'm really encouraging Ali and Ali Bhatia, his name is, and Course Karma to really bring all the courses in the world in dentistry and bring them together in one place. And that's what Course Karma did. But thank you so much for all of you who voted for me. Really appreciate it. The podcast did celebrate its second birthday recently. It was started at the very end of 2018, early 2019. So it's been 2 years. The very first guest, if you remember, was Surinder Arora, who was all about moving to Singapore as a dentist, so expat dentist in Singapore. So I just wanted to thank Surinder for being my very first guest. She's doing some great things. So if you're interested in yoga, or if you like the idea of yoga, she set up a new page on Instagram. It's at Dentists of Yoga. That's at Dentists of Yoga. So do check out Surinder because she helped me a lot with this podcast. So I'd appreciate if you would check out her page. So here's the Protrusive Dental Pearl for this episode. Remember at dental school where they taught us to use 3 fingers to assess whether your patient has trismus or not. So remember, if you use your 3 fingers and you check and they can open 3 fingers, then that's great. And if they can open less than 2 fingers, so you make it in your notes, okay, 1 finger, 2 finger, 3 finger. But one thing they forgot to tell you is that it's not your fingers, right? It's the patient's fingers. So for example, I remember back in the day, I used to use my 3 fingers and a petite lady would come along and my 3 fingers had no chance of fitting inside her mouth, right? So unless you're a petite lady, then it's not gonna work either. So remember, it's the patient's 3 fingers, not your 3 fingers. But how can we make this more objective? How can we check the maximum opening more objectively? Well, the easy answer is use a ruler, right? Use a ruler, and sometimes what I like to use is one of these. I'm hoping you can see this. There we are. It's from Great Lakes. It's called a range of motion scale. So this is a pretty cool thing to use. I'll put a little video in the background as I'm speaking about how I use this. The other thing you can do, which is pretty clever, is how about you calibrate your 3 fingers? Calibrate your 3 fingers. Just get a ruler, measure how fat your 3 fingers are, and so you know that, hey, your 3 fingers are 38 millimeters or whatever, and that can give you some form of a gauge, basically. So that's my Protrusive Dental Pearl. When you're checking for your maximum opening, be objective, use the patient's fingers, or at least use a measurement tool like a ruler or this range of motion scale. Now, when would you want to check the opening range? When is it important? Well, before any complex dentistry, I think it's important. I like to do it as part of my new patient protocol because it will be the difference between me referring that patient for a molar root canal versus me doing myself, right? Because remember, easy dentistry on a difficult patient is still difficult. So I've struggled the most when I'm doing posterior restorations and rubber dam on people with limited opening. So it's an important factor. You should be screening for it, I think. So it's a good thing to know. But also, if you're doing any splint work, then you'll find that actually when you make patients splints, their range of motion can actually improve. So typically, it's not uncommon to get 4 to 5 millimeters plus, depending on where they started, of increased mouth opening. So it's important to be able to objectively show that, because sometimes patients might come back and they think, you know what, I don't think this is working, because maybe they didn't have that many symptoms to begin with, right? And you're giving the appliance for more protective reasons rather than to help them with pain. But if you say to the patient, hey, before you were opening at 42 millimeters and now you're opening at 47 millimeters, it's important, it all counts. So that's my little tip for you today. So as part of making this episode and scripting this episode, I listened back to part 1. So AMSA part 1, I listened to that again. So hey, if you've ended up here by accident, you've just discovered my podcast and you thought, hey, let me click on this latest episode, it'd be really cool if you went back to the episodes in September, listen to the entire Splintember series, but particularly AMSA part 1, so that today's episode sort of builds on AMSA part 1. And I had to listen again to AMSA part 1 to help you recap. And I have to apologize, guys. I think it was complicated. It's partly because, hey, it's a complex field and I wanted to simplify it. But in a matter of 35, 40 minutes, however long the episode was, I really wanted to make it as valuable as possible and give you as much as possible. But by doing so, it can get more and more complex. So I'm so sorry if I lost any of you. I am trying to simplify it as much as possible, which is why I'm super excited to announce that very soon, the Splint Course will be launching. So it's an online Splint Course. It's www.splintcourse.com, and I'm so stoked. It's 4 or 5 years of hard work that I've worked on to bring this together. To really, the mission is to simplify splints for general dental practitioners. So I'm super excited to share it with you. In this course, splintcourse.com, I'm going to cover not only 1 or 2 appliances, but about 4 or 5 different appliances, what the indications are, how to identify who will benefit the most from appliance, like who are the true bruxes. And it's fascinating, because about 10 to 16% of all your bruxing and parafunctional patients are destructive bruxes. And it's fascinating research about what they do in their sleep and which phases of sleep they parafunction in, which determines what kind of bruxes they become. So there's a lot of research that I've put into this, a lot of reading of the literature, which I've done for you, which is just fascinating. I'm so happy to share that, because it helps you to make an informed appliance choice.
He's so enthusiastic to push the knowledge into your head. And I've really learned, I've been on some quite notable courses based around occlusion before, and I've really taken an awful lot from a 1-day course in comparison to a number of days. So yeah, really enjoyed it.
I talk a lot in the course about helping your patients with myofascial pain, and I go really in depth into anterior midpoint stop appliances. So something we've been talking about in the last episode and this episode, but really building on it with more and more videos, with more flow charts and design charts, and how to get the most from your laboratory and how to get your patient to wear the damn thing. So we go into real detail with that, but also how to get your bruxism patients to take ownership of their bruxism. Like, there's a difference between the patient who you've done anterior restorations for and they keep chipping it. And patient number 1 might be like, hey, you place these anterior restorations for me and they keep breaking. My fillings keep chipping, my crowns are chipping, I'm not happy. Versus the patient who's taken ownership of their bruxism, and they're the ones who come to you and after they chip something, they're like, hey, I'm so sorry. And they're apologizing to you. They're not blaming you, they're blaming themselves. Why? Because they know they have a bruxism issue. You've educated them. You've pre-warned them that this will happen, and you've also given them an appliance to manage that, because sometimes no matter how much canine guidance you have, no matter how much posterior disclusion you have, they will still destroy things. So these true bruxes, they will destroy anything that comes their way. That's why they destroyed their dentition to begin with. So it's super important we protect against the force of parafunction for these patients. Now you might say, Jazz, look, I don't want to be making splints all day long. I want to be doing beautiful dentistry. I want to be doing the full mouth rehabilitations. Well, I see appliances and splints as a precursor to that. I think you can totally use an appliance diagnostically in every patient you can be doing a raising of the OVD on for several reasons, including relaxing the muscles. Don't you want your muscles to be in a relaxed state before you start changing the vertical dimension. That's one, but also diagnostically to figure out who are those true bruxes. And there's a few protocols which I discuss in the Splint course, which I'm so excited to share with you. So if that's something that interests you, if you found these episodes useful, but you just need that one step more to be able to implement it, then this course is for you. Do check out splintcourse.com. The secret is if you actually register and put your email address in, I will inform you about the launch offer, which I promise will be worth your while. The last point on that is that all of the education I've done, all the courses I've done, all the mentors, all the failures that I've had chairside, which I will share with you in the course, they're all out there. Like you can totally go and start making your own splints and start trial and error and learn, which is fantastic. You can go to these courses, you can speak to some mentors, you can read the literature on this, which is vast and a lot of it's rubbish, some of it's golden. But what I offer with the Splint course is just to save you time really. So it's all out there. Everything you need for splints is technically all out there, but what I'm offering you is saving you time and saving you tears in terms of failures, remakes, and lab issues that you might get. So I hope you'll join me for that course, and that's my plug done. Let's dive into the education of AMSA Part 2. So in Part 1, we covered about how these appliances are not as evil as dental school first taught you. I sort of busted the myths about the appliances, these anterior-only appliances, acting as a dial appliance. We looked into that already in Part 1. We looked at how these appliances reduce resistance. And the analogy I used was that if you're lifting a really heavy weight, doing loads of repetitions and your muscles get tired, but then I give you a lighter weight, and suddenly your muscles can still lift that load, but it's so much easier compared to that heavy weight. Now, the heavy weight is similar to your patient who's locked in, and they've got this parafunctional habit due to sleep apnea, stress, gastric esophageal reflux disease, whatever it might be, right? And they've got this parafunctional problem, and they're trying to grind, but the muscles are locking them in. And what this does, it sends their muscles into overdrive. So you can just release that, then allow them to glide along, because it won't stop their parafunction, remember? It'll just allow them to parafunction in a more dentally beautiful way, which is essentially how any of these appliances work. So we covered that. And we also covered how you should avoid this appliance in people with intracapsular issues who are joint load positive. So you do a load test and it's positive. But you know, these patients are rare. So I find a lot of patients are amenable to AMSA treatment, but it's also to identify which ones may be high risk of getting anterior open bites. Remember, not because of the dial type movements, because of other reasons which I touched on. And again, at the end of this episode, I'll touch on again. In this part 2, we're going to cover about what's the difference between an NTI, an SEI, an MCI, a FOS. Like, is one superior than the other? So we'll look at the different varieties, different branding, and it's essentially just that. It's just branding, right? Like B-splint, E-splint. What's the difference? Is there a king of anterior midpoint stop appliances? I'm also going to cover some of the decision making that you have to do when it comes to AMSAs. Like, should I give an upper? Should I give a lower? Should we make them upper and lower together? When might that be overkill? When that might be the only real option to go for? So we're going to cover about some decision making. Now that can be quite complex, and I always liken it to arts and crafts of decision making. Like, you know, sometimes you can have to get out there, make these splints, and figure out for yourself, because there's only so much I can cover in these episodes. But you'll find out a few of the most common reasons why you might go for one arch over the other. I'll be talking about which of my patients have had anterior open bites after such appliances or any appliance, and how we got in that situation, how to solve that situation, or rather how to preempt that situation so it's not going to be an issue when it happens. Because why? Because you predicted it. You told the patient this was going to happen. So it's not even like you warned the patient, you told the patient. Sometimes you can tell them with quite a lot of conviction that it's going to happen. And remember, sometimes you want this to happen. Sometimes you want your patient to relax their mandible so much that they actually seat into centric relation, and it gives you all that lovely, wonderful space you want anteriorly to rehabilitate them. So that's one thing we'll look at as well, which is so key. And lastly, why an AMSA might just be overkill. And sometimes a patient, all they need is a bit of plastic between the teeth. Why? How sometimes by heating and melting the soft bite guard, you can actually get a really great, even soft bite guard, which is just crazy, right? You're thinking, what the hell is Jan's doing? He's recommending the most evil appliance of all, even more evil than AMSAs, right? The soft bite guards are really regarded in dentistry as a terrible appliance, and no one should have this. But hey, guess what's the most common appliance in the whole wide world? It's a soft bite guard. So let's make it even easier and more successful. And we'll talk about that as well towards the end of this episode. So let's look at those 4 things in order. The first one I said was, is there one AMSA that's superior to the others? To put it bluntly, no, not really. It's the technology, it's the science, it's the science of biting on your front teeth that's furthest away from the TMJ. That's the most important. Everything else is just dentists naming appliances after themselves. Remember the G-Splint? Remember that G-Splint I covered in episode 40 or 39, I think it was? So same thing, right? You want the most appropriate appliance for that patient, and it could be an NTI, it could be an SCI. So forget about the brands. I mean, there is one reason why I like the FOS, the FOS, the Flexi Orthotic Splint. It's because of the chemistry. The chemistry behind it is that the acrylic will actually bond to the polyester copolymer. Now, you can stick acrylic to NTI, SCI, what I call it, but there is no chemical bond. It will stick, but the material science is completely different to polyester copolymer. So that's the main advantage. That's why I switched to FOS. I find that to have a monoblock, so the acrylic joined to the FOS blank is a stronger appliance, and so far my patient's done very well over the years with that. So use any appliance you want. Speak to the lab. Which is your local lab? Which is a good lab that you know that is going to make these appliances? Two labs that I can tell you in the UK right now is PDS, that's Precision Dental Studio in Thatcham. There's a subset within there called Bite. They make great splints. So do S4S, who have supported me a lot over the years as well. So these are two labs I can tell you straight away that are going to be able to help you and guide you on your anterior midpoint stop appliances. And the US, I'm sure there are loads, in Australia. So find a lab, find a technician who's made loads and who can guide you. The main thing is for any anterior midpoint stop appliance, especially the ones that the smaller they get, is that make sure it's tight enough that they're unable to dislodge it with their lip or their tongue. So every patient, every fit, every recall, I always get their patients to bring their splint inside, because it's not a wham bam, thank you ma'am kind of appliance, right? You got to keep following it up, keep training them to bring their appliance in every time, and tell them, remember, if you can remove this appliance with your tongue or your lips like that, then it's time to contact me. Let's reline it. Let's make you a new one. That means it's end of its life, or just simply relining with acrylic. That's another benefit of using acrylic, actually. So you got to train your patients to make sure it's tight enough, and they should only be able to remove it with their hand. So remove it with their hand, completely cool. Remove it with their lip or their tongue, uncool. And of course, make sure no back teeth are hitting on clenching and or grinding. And sometimes you might think they're not hitting, but as their muscles deprogram, just like on a Michigan appliance, you see their jaw go back, back, back. It can happen on an appliance as well. And sometimes sometimes I always color these appliances in. And what they come back with is this like chevron, right? They come back with this like little V shape. In fact, I'll put a little photo up right now of one of these appliances that they make a pattern in, and that shows you where their centric relation is, and that's the furthest back their mandible can go. So it's great for diagnostics, it's great for patient communication, but it also shows you their range of movement as well. So it's interesting actually how the parafunctional range of movement is often higher than what they can achieve during the day. So if you get their range of motion during the day to be around about 10 millimeters, you might find that in their appliance at nighttime, they're going 12 millimeters or more. So it's really fascinating with the studies behind what you're doing in your sleep. Let's look at the second point, which is what kind of design is appropriate in terms of which arch should you choose for your AMSA? Should you choose the upper arch, lower arch, sometimes both? Well, the easy way to think about it is, and some things to consider in quick decision making is, if your upper arch has delicate restorations, let's say veneers, wouldn't it be good to get an appliance to completely cover those veneers or delicate restorations so that in power function, they're not taking any load at all? Because if you put the appliance on the lower incisors in that scenario, then even the upper incisal edge, let's say that's a veneer, is still taking load, right? It's still putting flexure and shear stress inside that luting cement. So it's sometimes good to incorporate your restorations within the splint. So whether those restorations are upper arch, quite commonly, or lower arch, consider that. How about crowding? If the lower arch is crowded, like you must have had this, right? Where the upper arch is completely aligned and the lower arch has lower incisor crowding, so common. And what you do is you make an appliance for the top, and you find that because you got crowding on the lower, you're always just hitting on one tooth, and then you adjust that tooth, and then you're hitting on the other tooth that's crowded, and suddenly you're spending ages, a long time grinding it to get the even contacts, and then suddenly in grinding you find that it's just one tooth taking all the loads again. So wouldn't it make sense to make the appliance on the crowded arch so that it's now up against the aligned flat opposing teeth, whichever it may be? So that's another sort of thing to consider in decision making, upper or lower. And sometimes you might have to go for a dual. Dual arch, like a top and a bottom arch, is good for your really hypertrophic muscles, your really strong grinders, because it gives them plastic to plastic. And plastic to plastic will always wear less than teeth to plastic, for example. So that's one thing that I like about that. And also, if you've got upper and lower crowding and the patient won't have orthodontics, then go for a dual arch sort of AMSA. So that way, the crowded arch is negated and the upper crowded arch is negated, and you've just got plastic to plastic meeting at the front, and you get all the benefits of an AMSA, which you discussed in episode 1. It's also worthwhile using a dual arch design when you've got retention concerns, because if you've got small teeth that are really worn and the patient doesn't want a rehabilitation and you're just putting them in a holding pattern and you're trying to figure out where the muscles want to go, so at that point you might find that if you're making a small AMSA, it ain't going to work, right? If you want to extend that now to involve more teeth, top and bottom as well, it'll give you more retention. So for example, in one arch, if you've got small upper teeth, instead of covering 2 to 2, extend that AMSA 6 to 6, 8 to 8, whatever you need to do to get it to grip onto more teeth to improve your retention. So that's another factor to consider. So each of those designs I just mentioned, whether it's upper arch, lower arch, or dual arch, there are some compromises and some considerations that you should have for each one. That is sort of going beyond the scope of an episode, because I want to cover a lot more things, but bear in mind that for every advantage, there's some degree of disadvantage for using each arch, whether it relates to patient comfort or a chance of an interference posteriorly, or raising the OVD too much. And those are the kind of things that you should be looking out for as well. So how many of my patients have had anterior open bites after giving these types of naughty, evil appliances? Well, around about 2-3 patients have had anterior open bites from anterior-only appliances, and 1 from a posterior-only appliance, which I didn't prescribe, but I just wanted to share that with you. I'm going to, in fact, show a photo of it now for those watching the podcast. For those listening, just imagine a posterior appliance only on the molars, which you can easily just buy on Amazon, right? But then you think, wait, Jazz, you just said a posterior-only appliance, shouldn't that cause posterior intrusion? I'm like, yeah, it should, right? But it caused an anterior open bite. So you know how often I've seen in the past on Facebook and stuff, people post an anterior only appliance and they say, this appliance caused my patient's AOB, these are evil appliances, stay away. Well, I can show you cases of AOBs from Michigan Splints, from Tanner appliances, from Essex retainers, from the posterior only appliances. Like, who would have thought, right? So there are other mechanisms at action. There's usually to do with the muscles relaxing. So the muscles can relax in any situation, including a posterior only appliance. So isn't that interesting? Now, with the anterior only appliances that I gave, every one of those, with the confidence I had, with the mentors I had, and with the education that I've sort of delved into splints more and more and more, I was in a position that with every one of those patients, I was able to tell them before they even had the anterior open bite that, hey, you know what? With this appliance, you will get an anterior open bite. And this is what you will look like. And so when it happens, they're like, yeah, what you said has happened. But guess what? Every time their symptoms went away, their muscle issues went away, and they weren't so concerned because no one smiles with their teeth together. And remember the whole thing about our teeth shouldn't be touching, lips together, teeth apart. That's the mantra. So a lot of these times it's not an issue at all. So what does it boil down to? Well, it boils down to communication. Did you spot that they were high risk? And B, how was your communication beforehand and afterwards? Like, if someone comes in with an AOB from appliance and you completely freak out and you call the police, then obviously the patient's gonna think, oh my God, something's wrong, my bite, everything's going wrong, the world's on fire kind of thing. But whereas sometimes patients come in from other dentists who've given anterior appliances and they come in and they've got an AOB, I'm like, oh, okay. Your front teeth used to meet, now they don't. How's that going for you? Everything okay? They're like, yeah, everything's fine, no issues. I'm like, yeah, that's what I expect. Don't worry about it. Just keep wearing your appliance. It's a good thing. And as long as it's not an aesthetic issue or a massive functional issue, then it's okay. Like, sometimes you have to warn these patients ahead of time that you may not be able to bite sellotape. So use these tangible examples. Don't say you will get an anterior open bite. That means nothing to no one. Tell them you may not be able to bite your nails again, which is kind of a good thing. I think I need an AOB for that. But you won't be able to bite your nails. You may not be able to bite sellotape anymore. And just give them these really tangible examples. So what are you thinking? Well, you're thinking, okay, Jazz, fair enough. But what are these high risk features? Well, I'm about to share with you the secret to figuring out who is at high risk. There's lots of factors, okay? But if I was to give you 3 main ones, right, it's the following. It's the patient, okay, who has got a minimal overbite to start with. Like they've got a 1 millimeter overbite. They've got like a 2% overbite or a 5% overbite, right? So if their jaw just shuffles back a teensy weensy bit, guess what? They have an AOB, right? They lose their coupling of the anterior teeth. So if you start off with a minimal overbite, then you are higher risk of getting an anterior overbite. Like you never ever get a deep bite patient and expect to give an appliance and for them to have an AOB. It's extremely rare. Like, whoa, like that's a unicorn right there. So these minimal overbite is number one. Number two is those who've got posterior instability. So instead of, posterior stability is when they bite together, everything just fits like a puzzle, everything fits together at the back nicely. But those patients who everything is just like flat, like they can bite in 4 or 5 different positions, right? So in that patient, don't you think that if their muscles relax, that they may actually forget to bite that Sunday bite that they usually have? That might change? Well, I think so, right? So it depends on the how well the teeth mesh together at the back. And the last one is they've got a significant slide between their centric relation contact point and their maximum intercuspal position. So I'm going to say that again. Their centric relation contact point, a large slide until their maximum intercuspal position, then surely if they were to relax, their muscles change their bite in any way along that path, something that the muscles might enjoy a bit more, then that will result in a change in bite and a change in potential the overbite into an anterior open bite. So I hope that wasn't too confusing because I know I'm trying to whiz through here, but I'm trying to jam pack as much as I can because I've got some communication bits coming up as well. So finally, point number 4 of the main things I wanted to cover in this episode about AMSA Part 2 is what if an AMSA is overkill? What I mean by overkill is we make AMSAs to help people's muscles relax, right? And there are some side effects of doing that, which I've mentioned exhaustively. And thankfully, most of our patients will not suffer these consequences. But any appliance you make has its own risks, right? So sometimes when you've got a patient who's completely asymptomatic with minimal signs of muscle issues and dysfunction, healthy temporomandibular joints, and you just want to give them something just so they don't bash into things and they have this low-grade parafunctional issue which is just above your threshold, or you've detected that there's a level of wear at which point you think it's inappropriate for their age. So it's pathological wear, not physiological, and I go over that in another series. But it's sometimes overkill to give them an AMSA. So why don't we just give them some plastic between the teeth? Like people are so quick to dismiss soft bite splints or the dual laminates, so soft on the inside, hard on the outside. Take it from me. Loads of my patients get these because I don't feel that they can justify the time, the expense, and maybe the patients themselves, they haven't taken ownership, right? So if the patient hasn't taken ownership of their problem and they really have put it like low in the value, because I charge a significant amount for my AMSAs and they're not ready to commit to that, sometimes instead of them going away with nothing, you can explain to them that, hey, you know what, I'm going to make you some passive fitting Essex retainers. Like we all can give that, right? So what I mean by passive fitting is that they must be comfortable to wear, because what you don't want to do is give a patient who's never worn an appliance before some really orthodontically tight Essex retainers, right? Thermoplastic retainers. You want to give something really easy to take on and off, because the chance of them swallowing or inhaling a large Essex retainer is more than any bridge or restoration that they have, right? So just give them that, but then just tell them, you know what? This is doing nothing for your joints. This is doing nothing for your muscles. It's just when you rub your teeth together, the plastic will take the hit. Let's see how long it takes you to destroy this. Let's see if you get any headaches or muscle issues, at which point we know that it's just tipping you above that threshold. And then we can make you something that, although it's going to be more of an investment, it's something that's going to be really better for your joints and muscles. How do you feel about that, Mr. Smith? Because it's usually the blokes who don't go along with this kind of treatment because they don't have any symptoms or any issues, basically. So that's another hack I want to give you, that, hey, you know what? Don't dismiss soft bite guards. I mean, interestingly, I think it was 1987 or 1989 where Jeff Okeson had that famous landmark study which proved that soft bite guards were terrible, and then they'll turn your asymptomatic patients into symptomatic patients, and many of them will get worse and whatnot. But when you read that paper, it had an N number of 10, right? Had an N number of 10, and everyone did well with the hard appliance, and about 5 people got a little bit worse. But I think if that's the basis of what all the decisions we make in dentistry now, then we need more than that. And actually, there's a randomized control trial that was done some years after. I might put it in the protrusive dental community, actually. where actually what they did in this study was they, instead of giving them just a soft bite guard, like in the Occlusal protocol, and not doing any adjustments, because in the Occlusal protocol, it said we didn't bother with any adjustments of this soft bite guard because it's near on impossible. And it used that word, impossible, right? But then some years later, RCT, which I'll share on the Protrusive dental community, they gave the soft bite guard, but they heated it. Or you can get an air, a blowtorch, something, melt it, get them to patient to bite into it and grind a little bit left and right. So now they at least got some degree of balance, right? And it's not just like hitting in one area, and it actually gets the anterior to touch just a slight amount. So can't you imagine that this might be biomechanically a superior way to deliver a soft bite guard than just a plug and play one? So that's an interesting one. I'll share that paper on the Protrusive dental community. So I hope you enjoyed that little reflection there about, sometimes AMSers are overkill. And I go over various different types of other appliances which may be all more appropriate on Splint Course. Now, one last thing to end with is a communication one. Now, as you know, I've been doing some group functions, which is where we come together as a Protruserati to answer questions. And I had Gurpreet on. He was supposed to be group function number 2, but Zach Kara came along and stole his thunder. But I'm still going to use his entry because he asked a really cool question. I've been mentoring a little bit, and we talked about these anterior midpoint stop appliances, and he sent me some photos of a case, and I sort of said, okay, make an upper or a lower here for this reason, and this is what you tell the patient, this is how you screen and stuff like that. So he said to me, what if it doesn't work? Like, you're charging, £450, which I told him to charge initially. He said, what if it doesn't work? And I said, wow, okay, this is something we can totally tackle in a group function. So I'm going to put that now, coming next is group function straight after this. But what about these appliances and you charge a certain amount of money? Like for me personally, AMSers can cost anywhere from a very simple one to an easy patient, a repeat appliance for someone who broke theirs or whatever, or lost theirs, is £450 to £850 usually. And a Michigan or a Tanner appliance is anywhere from £700 to £1,100, depending on the patient as well, basically, because there are some more complex features and some features of their personality or their malocclusion, whatever, that makes it easier. So that's the sort of range. So then it's common to start making appliances and having a feeling that, oh my gosh, I'm charging so much money for it. But think about how much chair time, how much expertise it takes. So you have to charge appropriately. So listen to this next episode. So I'm going to say goodbye and I'll catch you in the next episode. But then now I'm going to catch myself speaking with Gurpreet on a group function about, hey, what if I charge my patient for this appliance and it's not working? Okay, hi guys, I'm live. I'm live on YouTube. This feels pretty cool. I could have gone on Facebook, but this is a new software that I'm trialing at the moment. So because of that, I wanted to just try it out on YouTube. And this is a new arm of the podcast. So it's called Group Function. And it's sort of like an Ask Me Anything, but we're sort of working together more like a group. So it's the Protrusive dental community, if you like, working together to come up with the answers. The first couple I'm taking, but then as the questions come in, I'm going to pitch them to previous guests and future guests. So today on the show to cover a topic about splints is a really good question that was asked by Gurpreet, and I really thought a lot of people would benefit from discussing this. So I'm going to invite the Gurpreet who's called into the show now. Let's invite him on so he can ask this question, and let's see if we can have a chat about how I would approach that situation and see if we can get some value out of that. So I'm going to accept Gurpreet. His question is, what if my splint doesn't work? And we'll set some background in a moment because Gurpreet and I have had a chat about this already. So let's get Gurpreet to jump in. I'm just going to check my YouTube tab. Am I live? Yeah, looks like I'm live at the moment.
Good.
Hey, buddy, how you doing?
Well, how are you?
I'm very well, thank you. Thanks for coming on and agreeing to do this bit.
Thanks for having me on. Looking forward to finding your views.
No, so tell me, just set the scene. Set the scene about the patient you told me about, and what is the initial sort of dilemma, if you like.
Brilliant. So the patient's come in. She's been seen by multiple different dentists in the past, complaining of tenderness in her lower left 3 area. In the past, has been under the care of a hospital and has had a mouth guard, a full mouth guard, which has worked temporarily, but she's grinded through it. Then she was given a mouth guard.
Do you know if it was soft or hard? Have you seen the mouth guard and the night guard?
I'm not as being a thin mouth guard, which is what was different to what the last dentist prescribed, which seemed to be a slightly thicker one that she just didn't get on with, and she's not wearing it. Recently, she's had a baby. She was off work and recently started work again, so she's had stress. I was thinking that she may benefit from an anterior mid-stop appliance. And that leads me to the question. So I asked you for your advice. And to follow on from that, my question was, what if it doesn't work? Because these appliances are quite expensive. And if I'm charging the patient quite a lot of money for these appliances, how can I be sure that it's justifiable?
Okay. Really, really important themes, and I'm so glad you asked it in that way as well, because it actually adds another dimension onto it. So what I want you to do is I want you to mute your mic for a moment, because I'm hearing some echo. See if you can mute your mic. I'll see if I can do it for you. There we are. I've muted you, so you can still hear me, right? Okay, I've muted you. So basically, can you give me a thumbs up, Gurpreet, that you can hear me? Yeah, okay, sweet. So first, you talked about a patient, and the first thing that I sort of thought to myself was this patient has probably got obvious signs of power function because the previous two dentists gave a night guard, okay? So nowadays, the most commonly underdiagnosed thing in dentistry is parafunction. So if the patient has a night guard, two things have happened. One, a dentist has diagnosed that something's happening parafunction, okay? And it's probably been significant enough. And everyone's got a different threshold. And a lot of people wait until we got loads of dentine exposure before prescribing a splint. And two is that the patient's probably now come to terms with the fact that, hey, you know what? I parafunction. Okay, so that's the first thing I gathered. The second thing I want to address is that whenever you get a splint history, one of the easiest things to find out from your patient is, hey, was it rubbery? Could you bend it? Is it soft or is it hard? Because that sort of helps you to know what they've had previously. And of course, in the future, you can get them to bring it in again. Now, for those of you who are joining this group function and you've never heard of an AMSA, as you said, Gurpreet, an anterior midpoint stop appliance, listen back to a few episodes where we talked about, in Splintember series, all the different types of splints, but essentially a splint that sits on your front teeth. And to sort of cut a long story short, me and Gurpreet already had a bit of a preamble, a bit of a chat about this patient. And we think that the reason why this lower left canine is hurting is, and did you say there were some muscle issues as well? I've unmuted you.
Yeah, so the patient has had TMJ problems, and that's why she was under the care of the hospital. Since then, things have got a lot better, so she's been taken away from the care of the hospital, but the patient still reports having tenderness around her lower left three. Headaches, yep, occasional headaches, patient reports bilaterally. You did ask about muscle tension. Check the muscles. There wasn't anything significant in terms of the size of the muscles. But yes, headaches was definitely part of the history that she gave me.
Okay, so we're thinking a diagnosis of myofascial pain and also the fact that actually the canine, the reason her canine could be hurting could be, and I don't like to say could be due to the occlusion, but could be due to the parafunction. And if you're parafunctioning on a dodgier occlusion, then that could lead to it. So anterior midpoint stop appliances have two benefits in this scenario, okay? One is that it can be diagnostic. Is it the parafunction that's causing that pain or not? Now, if you give this appliance to a patient and the pain's still there, then we know that it's probably not the parafunction. Okay, so that's one. The second thing that we're doing here is helping the muscles to relax and hoping if the muscles or the parafunction is contributing to her tension and headaches, then that will get better. So it's very much diagnostic, potentially protective as well. And the other thing you mentioned was that there was no real muscle tension. When you palpated, there was nothing obvious, and quite often you will find that. Okay, it's not that common to find tension, but also you've got to make sure you're palpating in the origin and the insertion, for example. It's one of those sort of observations. Now, I agree with you that I think an anterior midpoint stop appliance would sort of do the three things that you want: protect the teeth, find out if the lower left three is hurting due to the parafunction, and see if the headaches will get better. So it fulfills the function, okay? But then you mentioned absolute fantastic thing, same mistake I've made before as well, and you talked about expensive. You use the word expensive, right? You say expensive, but the word expensive has negative connotations because, why do people buy £3,000 handbags, right? Like, why do people buy £30,000 cabinets, okay? Because they're looking for a solution. And the solution comes with a lot of value. So you're not providing a expensive solution at all. You're providing a valuable solution to that patient. So if the patient's problem is big enough, then that £400, £700, whatever, £1,200, whatever you want to charge, it doesn't matter. It's about what value can you bring to the patient. the value that you can bring to this patient, Gurpreet, is that you're actually potentially going to help her with a muscle issue. You're going to help her preventing further tooth surface loss, and also it's a diagnostic. Is this lower left 3 that's obviously bothering her enough to be able to come and see you as a dentist? Is it going to be fixed or not? So the money in this situation is regardless. But what you mentioned was a good thing that you mentioned, was that, hey, you know what? I'm giving this splint. What if it doesn't work? Okay. It's a bit like when you go for to a doctor, a cardiovascular doctor, and he puts a stent inside, and the stent has partially worked, but it's not partially worked. Are you going to imagine working in a private country, are you going to get your money back? Well, I think it's a lot to do with communication, and you have to communicate to the patient that, hey, you know what? I'm doing this on a diagnostic basis. Okay, this is a diagnostic appliance. I can guarantee that if you wear the splint every night, your teeth will not wear away, and there will be very minimal difference in years to come between your teeth now and your teeth in years to come, because you can guarantee that from any splint. Okay, so that should be your fail-safe. That should be something that a guarantee that you can always give. Okay, whether or not the muscles are going to get better or not, whether or not her headache's going to get better. Okay, the video's been disabled. Gurpreet, but don't worry, I know you can still listen up. So whether or not the muscles are going to get better, it sort of depends on whether if the parafunction was actually contributing to the headaches or not, and whether or not her muscle tension will get better will also depend on the parafunction. Now, my guess is yes, because 2 dentists have already thought that she parafunctions and she'll probably benefit from a splint. But the way you say to the patient that, hey, you know what, I'm trying to help you. I can guarantee that if you wear this and you get along with it, your teeth will not get worn down anymore. But let's see if we can get rid of your headaches, and let's see if we can get rid of this pain from your lower left 3. And if it doesn't, then we know that we need to bark up a different tree. So really it's two things here. One is a value. You're providing something so much more than just a splint, okay? And it's not expensive. It's very valuable to a patient. So that's what you should keep in mind. And definitely you can't overpromise. You have to underpromise and overdeliver with everything we do in dentistry, especially with splints, because some people will just not tolerate and get along with certain splints. If you get the diagnosis right, which I think you have done here. We think it's myofascial, and I think there is a good chance it will work. But it's how you frame it to the patient, and if you have to dissociate yourself from if the patient accepts the treatment or not. Okay, that's up to the patient. But you've done your hard work. You've thought about it. You've been to the Splint Course. You came to my Splint Course February. You spent time and money away from family, away from the practice to come and learn about this. You are ready to implement this, and you can really help a lot of patients. But it's about your mindset, and it's about how you pitch it to the patient. What do you think about that, Gurpreet?
Yeah, I think the day we had the conversation, it was quite an important one. I think it's all about not having these limiting factors for yourself and thinking about the bigger picture. For me, thinking about splints, the expensive side of things, but obviously for somebody who's been having these symptoms, the chance of becoming asymptomatic, not having these headaches is of high value. So I think definitely it's the way it's being pitched. To the patient, that makes a really big difference.
You are going to provide a valuable service for this patient, and it's going to be diagnostic, it's going to be protective. So don't worry too much about that, but definitely communication is important, and you sort of have to be confident in your approach that, hey, you know what, I've seen these 2 other appliances and I can tell you don't get along with them. What do you want to do? Do you want to just wear nothing and then bear the consequences of wearing no appliance on a parafunctional patient? Or do you want to have lots of dentistry to give you all this, canine guidance and all that sort of stuff? You can spend a lot of money there. Maybe the patient's not ready for that. But maybe by going through your approach, you'll get the benefit of having a splint that she can tolerate and be actually achieving all those aims that we said. So I hope that helped the sort of the way that you approach it. And I hope those who are listening have found this a group function, the second one, even though it's the first one going live, but it's the second group function that will probably go on the podcast soon. Gurpreet, thank you so much for being my second victim.
No, thank you very much. Okay,
sweet, buddy. You can see. I'm trying this new software. I have no idea how you can end that. So how do you leave? Can you leave? I'm going to give remove guest. There we are. I managed to remove Gurpreet, so I'm learning this new software. It's pretty cool, actually, how it can go live at the same time. People can call in, and we can take questions like that. So I hope you guys found that useful, and I'll be sticking this up on the podcast as a group function number 2. And guys, if you ever have any questions for past guests, future guests, part of the protrusive dental community, then we'll be able to tackle those together. And once again, thanks to Gurpreet for coming on and asking a very pertinent splint question that what if my splint doesn't work? Well, it's about how you approach that problem, how you pitch it to the patient, what promises you do make. You have to be very mindful for that. So over and out, guys. Thank you so much.